Okay, so over the next 15 weeks, we will cover lots of different things to do with metabolic medicine. We start off with cardiovascular disease, the basics today, and it is the basics. So I will go back to just explaining what cardiovascular disease is. And then over the next few weeks, I will cover coronary heart disease, atherosclerosis, cholesterol, triglycerides. I'll chat about diabetes, type 1, type 2, the complications of diabetes. At some stage, I will then go on to about the measurement of weight and about your basal metabolic rate and what that all is and what metabolism is. I then go on and cover osteoporosis, I believe, a little bit about the menopause, and also non-alcoholic fatty liver disease. Okay, probably quite a lot of things there you're not familiar with. Hopefully, I'll be able to give you the basics over the next 14 or 15 weeks. If you can't make any sessions, they're obviously
Living the dream. I just saw the
recorded. Okay, so they will be recorded. So if you can't make it on a Wednesday morning, but it's lovely to see everybody today. Okay, so some faces are familiar, lots of faces are not. So give me a little wave or a shout out if you're new.
Oh, no, I'm not.
All right, Kathy, Jackie.
New.
How do you pronounce your first name before I offend you?
Yes, Nadej.
Nadej. Okay, Nadej, great. Okay, so excellent. I think this is the biggest Wednesday morning I've had yet. Sometimes I ask questions. We don't do breakout rooms on a Wednesday morning. If you continue and go on to the Thursday mornings, although I think Elite's completely changed now. If you are an Elite or whatever they do now, I would advise you to do Wednesday mornings before Thursday mornings. Thursday mornings are a kind of continuation. So Wednesday mornings are all the basics. If you jump into a Thursday morning session, the chances are you may not fully understand what I'm going on about because I cover all the basics on Wednesday and then we build in that more on a Thursday and do some different topics on a Thursday. All right. Okay, so no breakout rooms on a Wednesday, do some of those on a Thursday, but I do ask questions. All right, so so just to make sure you're all awake at 8 o'clock on a Wednesday morning. It can, warning, there is a disclaimer with this, it can all seem like doom and gloom on a Wednesday and Thursday morning because I cover all the things that can go wrong. But the good news is we cover all the things we can do to prevent the things going wrong, okay? Or if things have gone wrong, what you can do to improve your health. All right. Okay, so cardiovascular disease, the basics. So cardiovascular disease, or CVD, is a general term for conditions affecting the heart and the blood vessels. Okay, so you've got your heart that pumps blood around the body, pumps it into arteries, which takes it to all your tissues, and then that blood drains back via your venous system, back to your heart and your lungs again, okay? Cardiovascular disease is associated with a buildup of fatty deposits, okay? Now, I like to call them fatty deposits or fatty plaques. I don't get any more complicated than that in clinic, but the technical or the medical term is atherosclerosis, which you may or may not have heard of, okay? And that results in an increased risk of blockages either in your heart, in your head, or in your legs, okay? And the damage can happen to your brain, your heart, your kidneys, and your eyes. Okay, that's where it will all manifest in your body, and you'll get symptoms from that. Now, cardiovascular disease is the main cause of death and disability in the UK, bar none. All right, I told you it was going to be all doom and gloom. Right, okay, that's great for a Wednesday morning. However, the good news is it's all preventable. Right, okay. Okay. So moving on to the different types of cardiovascular disease, because that encompasses several different types of disease. It's actually the same disease. It just depends which area of the body it's happening in. Okay, so we're going to chat about the heart first. All right. So that you can call ischemic heart disease, IHD, you may have heard of that, or CHD, which is coronary heart disease, but it is a part of cardiovascular disease. All right, so we're talking about your heart. Your heart is a big muscle. Okay, it's got 3 big arteries wrapped around it because the arteries have to supply the muscle because the heart needs a blood and an oxygen supply itself. And basically what happens in coronary heart disease is that flow of oxygen-rich blood to the heart is either hampered, decreased, or indeed blocked altogether. Okay, and that puts strain on the heart. Does anybody know the term, if you got some symptoms from having problems with your heart, what that's called? There's a term lots of people will know about, because they'll either know a mum, a dad, an aunt, an uncle, or a brother or sister that's possibly had problems with their heart.
Angina.
Angina. Excellent. Yeah. Okay. So angina essentially describes a decreased blood flow to your heart, and it's through these big vessels. Okay, and we'll come back to angina in a wee minute and go into it in a little bit more detail. And then progressing on from angina, if there's a big blockage and there's a blockage in one of the arteries and blood supply is stopped to a certain part of the heart, that is where you get a heart attack. Okay, or the technical term for that is an MI, a myocardial infarction. Okay, so myocardium is just the muscle, and infarction is just a blockage in the stop and supply of oxygen. And then as a consequence of your angina or your heart attack, or mainly your heart attack, that can then lead on to something called heart failure. Okay, because essentially what happens if you've got the blockage, even if the blockage has been unblocked, or you don't succumb to the heart attack per se, you will have damaged some of the heart muscle, and then that can put the heart under further strain, and that can lead to heart failure. Okay. Any questions about that? Okay, that's reasonably straightforward, okay, and most people will know about that because, as I said, there'll be somebody in your family or friends that have had issues with their heart at some stage, because it is very common. Okay, so the next thing we're going to move on to is, that's your chest, and then we're going to move on to your head. So what happens when you get a blockage in the blood supply in your head?
Stroke.
Stroke, yeah, okay. So essentially, it's the same process. You've got arteries, you've got two big arteries that run up, excuse me, through your neck that supply your brain, and then those arteries divide and take a blood supply to all parts of your brain. And when the blood supply to the brain is cut off, again, this can result in a stroke, which can result in brain damage or possible death. Okay, now, angina is the kind of, what I like to say, the warning shot for having a problem with your heart. Okay. So that's kind of giving you the heads up. And angina is something that happens, it's chest pain. And if it's stable, it comes on exertion, i.e. you may have walked quite far, or you may go up an incline, and you'll often get chest pain if you have angina, which is relieved by rest, because as soon as you rest, you're not putting your heart under any strain. And this is really easy to think about, because if you're walking along in the flat, I live out in the country, so if I walk along, there's hills everywhere. You're walking along, and you don't actually have to go up that much of an incline before you will feel your breathing has increased and your heart rate has increased. So next time you're out for a walk, doing your 10,000 steps or however many steps you're doing, have a wee think, or even just going up a flight of stairs. And I often ask my patients, do you have any issues going up a flight of stairs? If I asked you to walk up 2 flights of stairs, would that result in shortness of breath or chest pain? Okay. It's stable when the chest pain is relieved with rest. It's unstable when you get the chest pain when you're maybe sitting watching TV. Okay. And that's the warning shot. That tells you there's something wrong with your heart and you need to be reviewed by somebody, because that needs to get investigated so they can put things in place to prevent you having the full-blown heart attack. Now, there is a similar warning shot for a stroke. Does anybody know what that's called?
TIAs, transient ischemic attacks.
Excellent. Yeah, so a TIA, or a mini stroke, as I like to call them. Okay. Now, the difference between a full-blown stroke and a TIA, a transient ischemic attack, is it's the same mechanism again as the stroke, but the blood flow to your brain is only temporarily disrupted, and without any intervention by anybody medical, the blood flow has, or the tissues reperfused, the blood flow has got back to normal again, okay? And the difference between a mini stroke or a TIA and a full-blown stroke is the symptoms you have with the TIA have to resolve fully within 24 hours. Okay, so if they go on for longer than 24 hours, you've had a bona fide stroke. If they resolve within the 24 hours, it will be diagnosed as a TIA. But again, that is the same as your angina. Okay, it's a warning shot. It's letting you know things are not tickety-boo, so to speak. All right.
What would be the symptoms of a TIA then?
The same as the stroke. Okay, and I was just my next
sorry.
sentence is main symptoms. No, that's good. That's good. That means you're on the ball. So, okay, you guys tell me some of the symptoms of a stroke then.
Drooping of the face.
Yep, so facial droop. Okay, and you'll find it one-sided. Essentially what happens is the left-hand side of your brain controls the right-hand side of your body and vice versa. So if your blood is not flowing properly in the right-hand side, I would have a facial droop on the left-hand side of my face. Okay. And that's how you'll notice it, because it'll be an asymmetry. You don't get, all of a sudden jowls and everything goes down in a oneer. It's one side. It will be one side of your body. Anything else?
Slurred speaking.
Yep. Slurred speech. Excellent. Yep. One other important one.
Possibly loss of movement on one side.
Yeah, a limb weakness, and that might be an arm and leg. So you may drop a cup of tea, or you may stumble and fall. Because you've lost weakness, and again, that will be down one side of your leg. So you can get all of those with a TIA. All right, and there's lots of other things you can get with it. It's not just those three. There are lots of other things, but we'll go into those in detail at some other stage. But they're the same, Mary, essentially for a TIA, but the difference being is the facial droop, the limb weakness, and the slurred speech will all resolve within 24 hours.
Right, so it's the 24 hours that's the important thing then.
Yeah. Okay.
Thank you.
Yeah. So that's coronary heart disease, angina, and a heart attack, your head, strokes, and transient ischemic attacks or mini strokes. And then the next thing that you can get problems with cardiovascular disease is peripheral arterial disease or peripheral vascular disease. So that is either PVD or PAD for short, peripheral vascular disease. And this is essentially the same disease process, but it's happening in your peripheries, and it affects your legs usually way before it affects your arms. Okay, it's usually your legs because they're further away from you. So it's essentially a blockage in the arteries in the limbs, usually the legs. And how does that? So again, if you have a complete blockage, you would get ischemia in your limb, so your leg, so it would go cold and change color. And if you don't get reperfused, if you don't get the blood flowing again, you will lose the limb because it will become necrotic. All right. However, that's usually an event is not very common with your legs, but the chronic disease is more common. And the symptoms for that are kind of a dull cramping, leg pain, and again on walking. So you'll get a history from someone with peripheral vascular disease or peripheral arterial disease, and they'll say, oh, I used to be able to walk for a mile and a half in the flat. I can only walk for a mile, or I used to be able to walk for 500 yards. I can only walk 200 yards. And you get pain usually in your calf muscles. Again, to begin with, the pain is intermittent, and it's the technical term for that, and don't worry about this because it is a technical term, is intermittent claudication. So you'll take a history and the patient will tell you that they've got cramping in their calf muscles, and when they rest, so they can walk 500 yards, they sit down in a park bench, pain goes away after 5 or 10 minutes, they get up again, and then they can toodle along for another 500 yards. And again, if you ask them to go up a hill, it's more difficult. Okay. The other signs you may have, you may lose hair in your legs because they're not perfused as well. There may be numbness in the legs. And also, if you've got peripheral vascular disease, you can have problems with ulcers because essentially your blood supply isn't as good. So if you get a cut in your leg and that turns into an ulcer, it might be very difficult to heal. And that's just because your blood supply is really poor. So it doesn't heal as well. All right. And that's peripheral vascular disease. So that's heart disease, strokes, peripheral vascular disease. And then the fourth one that is common to cardiovascular disease is aortic disease. And that affects the aorta. So your heart sits just to the left-hand side, and the largest artery that comes out of that, the heart has got 4 chambers. And the left ventricle is the big chamber in the left-hand side that does the final squish. So when your heart contracts, the blood is pushed out of the left-hand side, out of the left ventricle into the aorta, and the aorta comes out of your heart and then curves down, and it then runs right down the middle of your body. Huge big tube, all right, biggest artery in the body, and all the other arteries come off that to give your gut a blood supply, to give your kidneys a gut supply, and then it bifurcates in your pelvis into your femoral arteries, and which run down your legs. Okay. So it's incredibly important, i.e. you can't live without it. And a common aortic disease is an aneurysm. So there's essentially a weakening in the wall and it bulges out the way. And if that ruptures, it's game over, not unless you're within a hospital setting. All right. Problem with the aortic aneurysms, they are usually asymptomatic. Okay, so heart disease, you can get a warning sign, you can get angina. Strokes, you can get a warning sign with your TIAs. Peripheral vascular disease, you'll definitely get the intermittent claudication, you'll get sore calves, etc., etc. But aneurysms, no, you will lightly be unaware of that. Some of them will be picked up just by scanning. You might be getting a CT or an MRI of your chest and abdomen for whatever reason, and they may pick up aortic aneurysm. Okay, so, and if it bursts, it is life-threatening. Sorry to hear that, Helen. Okay, so those are the 4 different types of cardiovascular disease. Anybody get any questions?
Hi there. Going back to the unstable angina, could you tell me what small vessel disease is in connection with angina? Because I did have a blocked artery, and when I first was diagnosed with angina in the left descending ventricle with a mitral heart valve problem, but they say that's all better. Seems to have cleared up with statins and that, but with the breathlessness and that I get at rest and sometimes exercise, but the angina attacks, they put it down to small vessel disease.
Okay, so you have 3 large vessels, as I said, that wrap around your heart. In fact, if you give me 2 seconds, I should be able to, I usually do, I'll do this next week actually, but if you give me a second, I'll see if I can find you a picture. Is that okay?
Yes, thank you.
Give me, oh, wow, this could be, right, okay. So can I find this quickly? I usually have this all set up before, because I'll chat about this next week, but let's see if I can find my picture of... No, that is not it. Okay. Ooh, there you go. Excellent. Right. Okay. Let's see if I can. Okay. I'll be doing this again next week, but let's just write. Oh, now I need to share this. This will be right. Okay. Ooh. Oh no, here we go. Share. Okay.
And do you want to?
Okay. Can somebody give me a wee nod? Because you guys all disappeared.
Yep.
See that? Yep.
Yep.
Okay. So, these are 2 of the vessels. This bifurcates quite quickly, and this is one of the other vessels. There's another vessel around the back of the heart, which you can't see here. Those are the 3 main vessels that they will look at when they put dye. They can either just do an MRI with a CTCA. Well, it's a CT scan, a CTCA they call it. Or what they also do is they can put a cannula into your down at your either your wrist or down at your femoral artery, and they put in dye, and they can have a look at what's happening. They'll pump it through these and they'll see if there's a blockage. Okay. By small vessel disease, these are the main vessels you can see here. Can you see these little vessels coming off?
Yes.
Okay, so there's not just 3 vessels that go around your heart. It's like anywhere, and it's the same in your brain. You've got these 2 big vessels that go up your neck and then go out to your brain, but there's tiny little vessels that go everywhere. There's tiny little vessels. Those are all called capillaries.
Right.
Okay. So what presumably, now I am not a cardiologist, but what presumably they mean by small vessel disease is those aren't as patent or as good as they should be. So there's nothing, when they go in and image or look at your large arteries, they can't see a blockage or a lot of atherosclerosis. But if you're still having issues, they'll put it down to small vessel disease.
Okay. Is there any way that you can improve that?
I think the way you improve that, and again, you should ask your cardiologist. One of the things for small vessel disease is particularly in your in your legs and peripheral vascular disease, collaterals are improved by just walking and more exercise.
Okay.
Because the more you exercise, the more and I'm not suggesting at all doing HIIT or anything like that, just more walking, moving, physical activity, swimming, cycling, whatever you do will improve, should improve your small vessels, because I think new small vessels will grow. That's definitely one of the things that will happen in your legs, okay?
Okay.
But it comes with a disclaimer, I am not a cardiologist, so you should ask your GP or your cardiologist about that, okay?
Yeah, okay, that's lovely, thank you.
Okay,
Can I have a quick question about aneurysms? Because I've heard that potentially there's some genetic element, and obviously I'd have some concern around that. Do you know if that's true?
pass. I don't know about
Okay.
the genetics of aneurysms. You would have to again consult your GP, or a cardiologist. All
Okay,
right.
thank you.
Presumably, if there was a strong genetic component, it depends, like anything genetic, what age something happens at. So if my mum, for example, had breast cancer, but I think she was just over the age of 50. So that's deemed not necessarily genetic. If my mum had breast cancer at the age of 40, there would probably have been more of a genetic component and I would have been screened for something like that. Okay.
Right.
So it will depend on the age of diagnosis. The older you are, if you get breast cancer when you're 70, 75, there's a lot less likelihood that it's a genetic predisposition. It's, lots of people. And when we chat about heart disease in more detail, and we chat about a genetic predisposition to having a high cholesterol in the upcoming weeks, I'll explain to you about a genetic or a family history in terms of cardiovascular disease. So a family history, a strong family history would be heart disease in a first degree relative under the age of 60 and a second degree relative under the age of 50. And a first degree relative is your mum, dad, or your siblings. Second degree would be your grandparents. So it has to be at an early age, because everybody that pretty much comes to my clinic that's over the age of 70 will have a history of heart disease. Okay, it doesn't mean it's genetic. They're 70. All right.
Thank you.
Okay. Right. So that's essentially the 4 types of cardiovascular disease. We're now going to move on to the cause of cardiovascular disease. We want to know the cause of cardiovascular disease because at the end of the day, we want to be able to prevent it or stop it from progressing as quickly as it possibly is. Okay. So the exact cause is unclear, and that's just because it will be multifactorial. Okay, so there's not just one cause that causes heart disease. However, we do know that there are risk factors that are important. And the more risk factors you have a greater chance of developing cardiovascular disease, whether it be a stroke, a heart attack, peripheral vascular disease, or an aneurysm. All right. So the way I like to chat about this is I have risk factors and I divide them into 2 groups, modifiable and non-modifiable. All right. We're going to chat about modifiable first. We're not going to chat too long about those because they're non-modifiable. They are what they are. You can't do anything about them. More interested in the modifiable risk factors. But let's just chat about the non-modifiable risk factors first. There are 4. Okay. Can anybody think of anything that is a non-modifiable risk factor for heart disease or cardiovascular disease?
Environment?
Your environment. I would say that's a modifiable risk factor.
Okay.
Age.
Because you can change your environment.
Oh, right.
Age. Yes, age. Okay.
Family
Age is probably one of the strongest non-modifiable risk factors because you're less likely to have a heart attack or a stroke at 20. I'm not saying you can't. I'm just saying you're less likely than when you're 80. So let's just take your heart as an aside here. It pumps between 60 and 100 pumps per minute every day, all day. So if you're 80 years of age, I've never done the maths, but let's say it pumps 80 beats per minute a day for 80 years, or 80 beats a minute for 80 years. That's a lot of pumps. All right. It's a cracking bit of kit, but you need to look after it. Okay. So age is a non-modifiable risk factor. Okay. Anything else?
You wait.
Again, that's a modifiable one because your weight can go up and down, can't it? So these are
Some sort of
non-modifiable. Gender, yeah,
Mhm.
or your sex, should I say. I'm going to do this sex, and by sex I mean XX or XY. All right. So, or male or female, but let's just say sex. So XX and XY, because I'm not going down that rabbit hole. All right.
Ethnicity.
Ethnicity, yes, ethnicity, and we'll come on to that later on, but ethnicity is important. And the other one is genetics. Okay. You can choose your friends, but you can't choose your family. All right. So, okay, so your genetics are your genetics. Okay. It is what it is. So essentially, yeah, age, cardiovascular disease is more common in people more than 50 years of age. That makes sense. Females, we're going to do a session about the menopause. Your risk of cardiovascular disease increases once you go through or peri or postmenopausal. Okay, but don't worry, we'll do a session on that. It's really important. In terms of sex, XY chromosome, men are more likely to develop cardiovascular disease at an earlier age. Okay, so they're more likely to get it in their 40s. When we get to menopause around the age of 50, we surpass men. And again, we'll cover that when we do that session. So ethnicity, generally talking about the UK, cardiovascular disease is more common in people South Asian, African, and Caribbean backgrounds. They are more likely to have an increase in blood pressure and type 2 diabetes, and those are both risk factors for cardiovascular disease. And I've given some of the modifiable risk factors away. All right. Genetics is the fourth non-modifiable risk factor. Family history of cardiovascular disease. You're considered to have a family history if you've got a father or a brother diagnosed with heart disease before the age of 55 or a mother or sister before the age of 65. And it's important to tell your GP about a family history of heart disease, okay, when they're looking at your cardiovascular risk. But again, we'll come back and do that. I think I cover all that in a Thursday session. We chat about cholesterol and genetics and things like that. Okay, so those are the non-modifiable, really simple. It's just age, sex, ethnicity, and genetics. All right, put those to the side. They're important because they can be used to look at risk factor, to look at models. We use mathematical models or calculators online to determine someone's cardiovascular risk, and they are taken into account. But we can't do anything about them. All right, so modifiable, as far as I'm concerned, in the clinic are more important because we can do something about those. Okay, so modifiable risk factors. I've given a couple away, but anybody else think of anything that is modifiable and is a risk factor for cardiovascular disease?
Diet.
Diet, yes, nutrition. Okay, so nutrition is very important. Anything else?
Smoking.
Yep, smoking, excellent. That will you'll learn over the next 15 weeks that I've got a real thing about smoking. Sorry, what was that one?
Stress.
Stress. Is that what you said?
Yes.
Yep. No, that's important. Yes.
Sedentary lifestyle.
Yes. So activity or inactivity are both important. Yep, they're both risk factors. Okay, there's the elephant in the room. We've already mentioned it.
Genetics.
Weight.
Yes, weight. So sorry, genetics is a non-modifiable risk factor.
Oh yeah.
Okay. Sorry, weight. Yeah. Okay. Weight is really important in terms of cardiovascular disease. Okay. So inactivity or activity, smoking, weight, diet, nutrition. Anything else?
Alcohol come into nutrition?
Alcohol, yeah, no, alcohol's a separate risk factor in its own because it's not involved in nutrition, I would suggest. Because it's not nutritious. All right. Okay. Yep, alcohol's important. I've got two others.
Drug use?
Drug use. Yep. That's one of them as well. It's not the two I was thinking of, but yes, drug use. You can have a heart attack at the age of 20 by using cocaine. All right. Cocaine can result in coronary spasm, coronary artery spasm. Okay, I mentioned, okay, so I'll give you a starter for 10, fatty plaques.
Oh.
Cholesterol.
Cholesterol, yes, high cholesterol, right. And then one more that I've already mentioned when I was chatting about ethnicity, I mentioned this. There's another big risk factor, diabetes. Excellent. Right. Okay, so let's have a look. Oh no, I've got one more, in fact, and it's probably one of the most important ones we haven't covered. I don't think we've
Oh,
covered it.
high blood pressure?
Yes, high blood pressure. Okay, so high blood pressure, the technical term for that you may have heard is hypertension. Okay, really, really important risk factor for cardiovascular disease. So if your blood pressure is high, it can damage your blood vessels. If your blood vessels are damaged, that increases your risk of laying down the fatty plaques. If you increase your risk of laying down the fatty plaques, increased risk of blockage, heart attack, stroke, peripheral vascular disease. Okay, blood pressure is really important. Right, smoking. Now, we're going to go through all of these over the next few weeks, so I'm only going to say a few words about each one, okay? Because we're literally going to do alcohol and smoking in a session. We're going to do diabetes in a session, a couple of sessions actually. We're going to do about cholesterol, etc., etc. So we're going to do all of these. So smoking is a significant risk factor. Lots of people tie smoking in with lung disease, okay? Either lung cancer or chronic obstructive pulmonary disease, COPD. Everybody will know somebody with that or know somebody that knows somebody with that. So smoking and lung disease is very well known. Smoking and heart disease, not so much. All right. Essentially, smoking does two things. There is harmful substances in the tobacco that damages your arterial wall. And as we've heard, if you damage your arterial wall, you're more likely to get fatty plaques. The laying down of cholesterol to make the fatty plaques is accelerated by smoking. And again, we'll do that when we chat about cholesterol in more detail. So smoking is a no-no, which is why I'm really not a lover of smoking. Now, I'm very lucky I've never smoked. It's addictive. I get that. There's stuff in it that makes it addictive. Okay, so I appreciate that it's difficult to stop smoking, but I'm just not a great lover of smoking.
Caroline, is there any evidence around the impact of secondary, like living with people who do smoke? Or is that?
There probably, well, there is for lungs, whether there is for heart disease, I would imagine there probably will be. You know, I wouldn't want to sit in a room with a smoker for all sorts of reasons. I think anybody that currently smokes should, if they're in a house, should do it outside, and they should definitely when they've got children, because there's a definite link between passive smoking and asthma and things like that, isn't there? So
What about being around people who are vaping?
yeah, vaping, I think vaping is smoking. I think we're basically history's going to repeat itself. The fact that vapes, yeah, they were first invented, I think it was the 1950s. It was a Japanese guy that wanted it because his father had lung cancer, I think, and he wanted to design something. The whole point of a vape is to go from smoking to vape to stopping, not to vape when you're 12. And my son gets this a lot at the dinner table when his mother is going off on one about vaping. It is absolutely heinous that we have got the same problem with vaping now that we did with smoking 30 or 40 years ago. Yeah, so I think vaping, there's no way you can inhale particulate matter into your lungs and that's not going to have the same effect as smoking. It's just not. Just because
I get somebody at work does it, and as soon as she starts doing it, I get irritated in my.
But she should. But presumably she doesn't do it inside at work, does she?
Well, she does it outside the back door, and sometimes I've stood there chatting to her, and I've started to cough because of the.
Yes, I would. I wouldn't stand at the back door when she's vaping. That would be my advice.
Absolutely. No, well, I don't anymore, but that's what happens.
Even if it does smell of cherry bakewell or whatever, or banana or whatever they seem to do. I mean, I know it's absolutely horrendous. Yeah, not good, not good. Okay, so that's smoking and that's blood pressure, high cholesterol. That's quite an obvious link with heart disease because it is the fatty plaques is composed of cholesterol. And again, we're going to do a whole session about cholesterol, good cholesterol, bad cholesterol, and how that whole process works. Okay, so you don't want to have a high cholesterol. Diabetes, type 1 and type 2, not just so type 1. And again, we're going to do sessions in this. Type 1 diabetes is you can't make any insulin, so you have to take insulin. Type 2 diabetes, you're still producing insulin, but you're insulin resistant. Again, we'll do a session on that. When with both types of diabetes, your blood sugar levels are higher than they should be, and this can damage your blood vessels. Okay. Type 2 diabetes is also associated with having weight, and especially truncal weight around your abdomen. So that increases your risk of heart disease as well. All right. Inactivity, no or little exercise. So if you don't exercise, you're sedentary, you sit on the sofa a lot. That will result in increased blood pressure, increased cholesterol, because exercise affects your liver, which is the big organ that deals with cholesterol. And again, we're going to cover this, and it can result in weight gain if you're not expending the energy that you're consuming. They all increase blood pressure, cholesterol, and weight all increase your risk of cardiovascular disease. Exercise can do lots of different things. You're now quite a way down your TSD. You'll know that if you're doing your resistance training, you're trying to build muscle up, which is good from a metabolic point of view, and it uses the glucose when you consume it, when you're eating. The cardiovascular exercise is important because that is working your heart and your blood vessels, and it keeps them more pliable and more elastic as you get older. Your blood vessels in the inside are getting more stiff as you get older, but like your skin's not, your face isn't what it was like when you were 20. The inside's not what it was like when you were 20 either. Okay, so exercise regularly, healthy heart, etc., etc. Okay, weight. Okay, what has weight got to do? Weight, your waist circumference is a really good indicator of your risk of cardiovascular disease, bar none. And we're going to do a session about how you weigh your, or how you determine your weight, whether it's body mass index or waist circumference, etc., etc. But your waist is a really good indicator because there's two different areas where you put weight down. You can put it around your hips, or you can put it around your abdomen. Pear and apple. Okay. Apple distribution, which is more common in females postmenopausal. That weight around your abdomen is metabolically active. It affects your liver, and it increases your risk of heart disease. When you're overweight, you've got increased blood pressure, because we know when you lose weight, your blood pressure comes down. You've got an increased risk of insulin resistance, type 2 diabetes, and both of those increase your risk of cardiovascular disease. All right, so that's why weight's really important. Diet. Okay, we'll chat about this throughout all the chats I'm going to do. One of the specific things in diet, 30, 40 years ago, it was low-fat diets. And as a result of that, everybody went on to high carbohydrate diets. Unfortunately, it was, nobody was eating fat, everybody was eating carbs, but it was refined carbs, all right? All carbs are not created equally, okay? The fat you want to be careful with in terms of cardiovascular disease is saturated fat, because that results in an increase in cholesterol. There are other types of fats, though, that are fine, like your omega-3 fish oils, etc., etc., and the fats you get from nuts. They're all okay. You just won't eat a ton of nuts, because if you're watching your calories, you'll know you can't eat a bag of them. All right. So saturated fat is not good. That increases your cholesterol. Refined carbohydrate intake, which, if you ask my 13-year-old son, is all the crap. And I know we're not allowed to say foods are good or bad, but let's be honest, that's how it works with a 13-year-old. So refined carbohydrate results in an increase in triglycerides. And don't worry, you may never have heard of triglycerides before. We will cover that in a session. Okay, but that's the fat. That triglycerides are the fat that we store energy in. All right. And both of those, cholesterol and triglycerides, increase your risk of cardiovascular disease. Okay. Alcohol is another modifiable risk factor. What does it do? Alcohol affects your liver, gives you a fatty liver, and your liver is the big organ that controls your cholesterol and triglycerides. So alcohol will increase both of those. Alcohol also increases your blood pressure. It also gives you additional calories, so it can result in an increased weight. So you can see these all tie in together. If you've been writing these down, you can be, you could have a spider diagram where there's arrows just going everywhere, because they're all linked to each other. All right. Okay, so those are your modifiable risk factors, and they're really important because they're modifiable, so we can do something about them. All right, which is really important. So, Any questions about that? I'm just about to move on, preventing cardiovascular disease, so healthy lifestyle. I'm going to chat about that for a little minute, but has anybody got any questions about the modifiable risk factors?
Yeah.
No, good. Right. So cardiovascular risk reduction. What do I chat to my patients about? Smoking in terms of cardiovascular disease is my number one, even before weight loss. All right. And I'm going to show you a graph about that later on when we do smoking and alcohol for the week. Okay. No problem, Sharon. Hope you have a good week. So stop smoking. All right. It's probably the most beneficial thing you can do for cardiovascular disease, bar none. Smoking, there's a real link between smoking and peripheral vascular disease. If you ever have to be sent, if you're sent to a vascular surgeon, they will basically turn around and say, you cannot smoke. Peripheral vascular disease is really, really affected by smoking. Okay. Peripheral vascular disease can be horrific because you can result in amputation. You can lose a limb. All right. Okay, so that's smoking. Diet, nutrition. So balanced diet, decrease your saturated fat, watch your salt intake, and we'll come back to that in another session. Sugar, refined carbohydrate, increase your fiber, increase your whole grains, increase fruit and veg. So simply brown, not white, and eat the rainbow. If you want to take anything away about nutrition, that's how to do it in kind of 2 sentences. Okay. Activity or being sedentary. So exercise regularly. You guys, I don't need to tell my grandmother how to suck eggs. You guys will all be doing steps, doing some resistance training, whether it's resistance bands or Olympic barbells or somewhere in between. Walking every day. What I think walking's fantastic. Walking's one of those things. I did walk before TSD, but I didn't put as much effort into it as I do. Walking's one of those things. And walking's the really good thing. I like walking because if you've had a really rubbish day, you can bring that back. You know, you may not have been on target with your diet, for your nutrition, whether you've been busy or whatever. You may not have been able to do that resistance session you wanted to do, or go to the swimming pool because you had to drive to the swimming pool, or whatever you do. But walking is the one thing at the end of the day I can say, right, I didn't do X, Y, and Z today, which I wanted to do, but I got the steps in. All right. And we're going to chat, when we chat about diabetes and insulin resistance, we'll talk a lot about moving and walking and what you need to do within 60 to 19 minutes of eating. Okay. So regular exercise keeps your cardiovascular, your heart and your lungs healthy. Resistance training allows you to take a few more calories and lets you get the glucose into your muscle cells as opposed to being converted to fat and being stored. Exercise will help maintain weight loss, will help with weight loss, and will decrease your waist circumference, which is really important in terms of cardiovascular disease. All right. So that's exercise. Right. Cut down your alcohol. Recommended units per week for an adult in the UK. Anybody know them?
Don't drink.
4 units.
Pardon?
4 units.
Oh, 4. Yeah, that's about right. But no, unfortunately, it's 14. It used to be 21 for men and 14 for ladies, but it's now 14 for both. Okay. Should be over at least 3 days and not, you know, on a Friday night, all 14 units. We're going to cover alcohol, so I'm not going to say anything else about that. Assuming you're watching your calories and TSD, I don't think anybody will be probably drinking 14 units a week, for the simple reason that you wouldn't be eating if you were drinking, because it will take a lot of your calories up. Okay. There are means and ways of getting around that a bit if you still want to enjoy a drink, which we'll discuss at some stage as well. So medication is important in terms of mitigating risk as well. The one I would think of, or the two, would be blood pressure and cholesterol. If you're recommended to take blood pressure or cholesterol medication, do so under the say, of a doctor, especially blood pressure. Your blood pressure will come down as you lose weight and you start to exercise, etc., etc. But if your blood pressure is high, it is not a good idea just to stop your meds and see what you can do with exercise, etc., etc., because you could have problems with a stroke or whatever in the interim. So that should all be guided by your physician. I think one of the girls, Deborah Hunt, that's on the Inner Circle and does lots of stuff. I think she was on 4 blood pressure medications, and she's either off all of them or she's on 2, and they're very, really low doses now because of her weight loss, which is absolutely phenomenal. Jackie, something flashed up there. Yeah, excellent. Whoever said they were reducing their meds. Excellent, really excellent, good result. Okay, so less meds are good, but do not come off your meds until indicated by a physician. All right. Okay, so that's about everything about coronary heart disease and the modifiable risk factors. So that's the advice. Those are the things I sit and chat about. Now, you can give other advice out with that. One of the things I talk about now is sleeping. Okay, stress is another thing that people have to be aware of. So your physical activity could include things like meditation or yoga, things like that. Okay, sleeping I think is really important, and it's something I do talk about patients. It's not in as one of the risk factors per se, but I would argue sleeping has a knock-on effect to lots of stuff. Sleeping has a knock-on effect to your physical activity. It has a knock-on effect in your diet, et cetera, okay. And yeah, because you might make poor food choices if you're tired, and also you'll not exercise if you're tired either. All right, okay.
Yeah.
So any questions about that?
I have hemochromatosis. I know that affects your liver, but does that have any effects on your cardiovascular or anything?
Sorry, Heather, I missed the beginning of that question.
I have hemochromatosis.
Hemochromatosis. No, it shouldn't,
I
as
know
long as
that
it's
affects
being
the liver,
treated.
but yeah.
No, as long as you're getting treatment for that, hemochromatosis should not have an effect on heart disease.
Okay, yeah,
or
I'm waiting for
cardiovascular disease.
transport to pick me up for venesection today. So
Yep, no, that shouldn't. As long as you're getting looked after, that shouldn't increase your risk. Anything else? Anybody need anything clarified? So just quickly to go over it, cardiovascular disease includes heart attacks, chest, strokes in your head, peripheral vascular disease, and aortic aneurysms. The non-modifiable risk factors are your sex, your age, your ethnicity, and your genetics, your family history. Can't do anything about those, but the modifiable risk factors include your diet, exercise, cholesterol, smoking, blood pressure, diabetes, and alcohol. All right. Okay.
On the alcohol, is a unit still 50 ml? Is that because it used to
No,
be
because
50
it
ml?
depends. I'll do a session on alcohol. It depends. No, because yeah, and this is the problem. The 14 units, it's all based on kind of lots of alcohols are different strengths now, aren't they? So yeah, so you've got to sit and work out individually, and I'll do alcohol, what a unit is. I think is it 8 grams per litre a unit is kind of thing, but no, it's not as simple as that. In terms of alcohol in work, what do? I usually multiply what everybody tells me by 2 in my head. But anyway, no, I'm only joking. No, I do. Same with smoking, right? So basically a pint of beer to me. Now, beers will be completely different strengths, but I can't sit and say exactly what beer do you drink in this, that, and the other. That's not going to happen in clinic. So a pint is 2 units. A glass of wine is 2 units. Wine can vary from 8 units a bottle up to about 16 units a bottle, depending what type of wine you're drinking. I kind of take it as 8 units a bottle. All right. So if you're drinking 3 bottles of wine a week, you're drinking 24 units as far as I'm concerned. It's probably higher than that. All right. But if you're already drinking 24 units a week, I'm concerned that you're drinking too much alcohol, and I will have conveyed that in clinic. And then a spirit would be obviously one measure of a spirit would be a unit as well. But yeah, no, it's hugely complicated. It's not as straightforward as it is, and we're still working off what they designed in the 1960s or 70s in terms of units. So, but if you sit down, I guess it doesn't. Yeah, I want to kind of, and it's usually, people say, I have 1 drink a week or 2 drinks a week, and then there's people drink every day. The ones that are kind of surprised, the ones who drink every day or drink a lot will tell you, and they'll tell you exactly how much they drink, and they don't have an issue with that. And then there's the ones that don't drink. It's occasional. I don't drink very much, maybe at a birthday or something. I could go for a month without drinking. It's the people who probably drink a glass or 2 glasses of wine a night, most evenings with their dinner, and they have no idea what they're consuming, because the glasses now are not 125 mils. Your glass at home will be 250 mils. So a good way to look at that is how many bottles of wine are you going through a week between you and your partner or whoever's in the house with you. Okay. And when that's racking up to 3, 4, 5, 6 bottles a week going into the shopping trolley every Saturday or Sunday, you're drinking too much alcohol. All right.
No, definitely not that much.
All right. Okay, well, look, lovely to speak to everybody or see everybody today. I mean, absolutely fantastic. really, really good that there's so many people here. And I will be back next week, next Wednesday. Okay. And I hope you all have a lovely week. All right.
Okay.
Thanks.
Thank you very much.
Take care.
Thank you.
Bye.
Bye.
Right, bye.
Bye.